Now, the last part of the instruction course is the last talk by Dr. Vishali Gupta, and will be talking on the most important part of this, which is very relevant to the practitioners. Which patient and when should you refer to a uveitis specialist? And to deal with this topic, none other than Dr. Vishali Gupta, Professor Vishali Gupta from PGI Chandigarh, who is extensive experience in treating uveitis cases, will be talking to us. Professor Vishali Gupta.
Thank you, Dr. Biswas, for the kind honor to invite me. So the topic that Dr. Biswas has asked me to speak on is which patient and when should you refer to a uveitis specialist? So I'm just going to give very simple, basic clinical scenarios which while in your clinic you see, you should be thinking about referring those patients. Now, the first clinical scenario is I look at the patient and I know it's potentially blinding, devastating disease, which needs very aggressive management and close monitoring for the complication. And the typical example is acute retinal necrosis. Arm has changed its behavior post-COVID. We do need to supplement a lot of these patients with intravitreal therapy, which was not the case earlier. And we are developing retinal detachment in the very acute phase somehow. I see active retinitis and retinal detachment, bilaterality. So these are the cases, if you are not comfortable, it's best to let them go to a referral center where they can be handled, because once complicated, it becomes a real problem to manage these patients. The second is I have a look at the patient and I suspect, and I'm not very sure, whether it could be an underlying malignancy or a masquerade. So if that little voice comes in your head when you are looking at the patient that could it be malignancy, don't take any chances. Don't start the patient on steroids because steroids could potentially mask the underlying masquerades. So this is an example. For example, you see these subretinal spots in a patient, few vitreous cells hanging in there, no synecdoche. You know it is not choroiditis. You do OCT and you do realize there are RPE deposits. Refer these patients. It's better to have the biopsy straight away rather than prolonging the course. Or you have a patient where there are pigmentary disturbances, something going on, and you cannot put your finger on. Best is to keep them treatment naive and refer. The third scenario is I look at the patient and I just know what the hell is it. It happens to all of us at times. And these are some of the scenarios. This is a young boy who comes. Within 3 days, he's gone down to counting finger in the left eye and is 660. And you see these full thickness, retinitis lesions, necrosis. If you do OCT over this, only ILM would be there. The rest of the retina is eaten away. So these are not the usual cases. Something is unusual. This is actually measles virus, SSPE, but it may not be SSPE. It may be anything. If you do not understand what it is better to refer it straight away without getting the usual investigations or trying therapies, which and any therapy for that matter. The fourth is a scenario where the patient is already under your care, and whenever you start some therapy based on the investigations, you do expect some response. For example, a simple case, BKH, you have started on IVMP, you know that within 48 hours or 72 hours, the exudative detachment has to go down, the choroidal thickness has to reduce. So you have a certain expectation from the treatment. if you have initiated the treatment and the patient is not responding the way you thought patient should respond, it's again better to get a second opinion. I'll give you an example of this patient. On the top, you see these nasal lesions. The autofluorescence shows they were active. So it was diagnosed as TB SLC, test positive for TB, initiated with anti-TB and systemic steroids. But the bottom shows the worsening, and now we have the lesions in the posterior pole and active one. We know it is paradoxical worsening. So this is how it goes, and paradoxical worsening, you give DEX implant, 1 week post DEX implant, 3 weeks post DEX implant, and we see the new lesions appearing. We tried intravitreal methotrexate. Again, the lesion keeps on progressing. And finally, I put my neck on the block and gave intravitreal adalimumab, to which the patient responded. But the thing is, if the patient is not responding the way you would have expected the patient to respond, it's always better to refer to an institute where some newer therapies or something can be done. The fifth scenario is patient is having multiple recurrences every time I reduce steroids and I have no experience with immunomodulator therapy, or I have a patient presenting with a condition which is likely to have multiple recurrences and I want the patient to start immunomodulation, but as a comprehensive ophthalmologist, I'm not very confident. And this is one such example is the VK8, Sudarshan showed, sympathetic, Behçet's, JIAs, TINUs, all these patients are the one who right in the beginning, you know they require immunosuppression. Making a diagnosis of VKH is one of the easiest diagnoses in uveitis. You see these patches, you see choroidal thickening, you see these on ICG, and you do see retinal detachment exudative with basilar layer detachment, and you know it is VKH. The problem is you want to start immunomodulator, and if you do not have the facility, please refer. Sixth scenario is patient is not having typical phenotype, and I'm kind of confused. Like, what is it? Because there are cells there. Is it intermediate uveitis? Why does intermediate uveitis have these changes? There is cystoid macular edema. Is it inflammation? Is it something else? Well, this was CRB1 mutation. And lot of dystrophies and Fuchs patient. I see them, somebody diagnoses them with vitreous cells. They think it is intermediate uveitis in a retinitis pigmentosa patient. It doesn't work that way. Those dystrophies do have inflammatory cells. You just need to figure them out and not treat it. Fuchs patients are going to have cells and opacities in the vitreous. They do not require immunosuppression. So whenever you are in doubt, you are not sure that it's not fitting in a straightforward diagnosis, please refer the patient. The seventh one is that I'm unable to make up my mind whether it is uveitis or endogenous endophthalmitis. And this is one such example. This patient was actually fungal endogenous endophthalmitis, and you can see there is a buccal. The buccal got infected, and this is how it was coming. And somebody was treating it on in a patient who has a silicone-filled eye following vitrectomy. So if you are ever confused because it's not fitting in the scenario, just refer the patient, because this is how we ended up. He kept on receiving IV acyclovir, progressed, and actually this is fungal. Eighth is pediatric uveitis. Please refer children. Children do not give us time to reverse any of the complications, and do not try too much steroids in children before giving up. This is a patient of TINU, and the urine examination showed increased beta-2 microglobulins. Another thing is all children, uveitis is not JIA. We were ignorant. We used to diagnose it as GIA, but there are a lot more entities we need to look for. We need to be more aggressive in giving biologics. So please do not refer when everything is failed. For children, refer it in the beginning so that it is a step down approach and not step up. Children with hypopion, leukemias, retinoblastomas, all these need to be ruled out, so do not take chances. This is a patient with ALL. Not only pediatric, the geriatric uveitis, the masquerades need to be ruled out. The immune system is too tired to produce autoimmune disease after 60s and 70s. So the patient with first episode of uveitis in the geriatric age group, do not think of immune-mediated response. Just refer the patient because masquerades would be very high on card. For example, this is a 62-year-old woman, new onset vitreitis, and over a period of time develops typical spots of lymphoma. But even before that, this is not the age to get intermediate uveitis. So keep your options very well opened. And just do the OCT, which shows deposits under the RPE, and that is it. And last one, if you're planning to do cataract surgery, because I'm talking to comprehensive ophthalmologists, you know, they love cataract. They just see anything white and they want to take the patient to OR. Please don't do it to the complicated uveitis patient who is not under your care, because the risk of phthisis is very high. And do not be tempted to put an implant in a JIA patient. We have come out with our 30 years longitudinal follow-up, and despite everything, it's a bad thing to do in children. It's better to do a good workup, control the inflammation for 6 months, do the UBM, and then plan the surgery according to the needs. So if you have a situation like that, please refer. So to conclude, please refer whenever you are not sure of things. Moral of the story. Thank you very much, sir, for the kind opportunity.
Thank you, Professor Vishali. I exactly wanted these things to be highlighted. And